Hey, and welcome to this presentation on sciatica. Today I'm going to be showing you how to fix problems instead of only treating symptoms, and especially how to avoid pain meds, cortisone injections, and surgery. My name is Dr. Derek Nilsson. I am the owner of this physical therapy clinic in the bottom left, Kaizen Physical Therapy. And let's jump right into it. So I'm going to show you a simple step-by-step process for how to discover where the root problems are that's causing your pain. This is the exact process I use with every single patient who comes to me with back pain or sciatica. But first, before I jump into that, I want to show you exactly what traditional healthcare gets wrong for people who suffer from pain. So this is me, Dr. Derek Nilsson. This is the only time you'll see me, just because I want you to be able to focus on the slides so you get the most out of this presentation and it can help you with the most to start getting out of pain. So healthcare focuses too much on symptom control. Treatments are provided solely to shut off the pain and are only concerned with where the pain is felt. You probably already know this. Cortisone injections, pain meds, anti-inflammatories, muscle relaxers, they're all just worried about symptom management and not finding and fixing the problem. I compare it to something like this picture. So if you're driving your car down the street and you see a check engine light on your car, the first thing you do is not try and find the fuse in order to shut off the check engine light. You want to figure out what the problem is. But in healthcare, when it comes to pain specifically, they are generally just focused on the symptoms. They just want to turn the symptoms off, just turn the pain signal down. And that's similar to finding the fuse that's in charge of the check engine light in your car and turning off the check engine light. Well, you didn't really fix the problem. You just turned off the light so that it seems like there's not a problem. And today I'm going to show you how to find and start fixing the problem of what's causing pain. So the biggest misconception in the treatment of pain that I see and hear is people saying that they need an X-ray or an MRI to know what's wrong. Well, let me ask you a question. Tell me which person here has pain, back pain or sciatica, because it's very likely that if you suffer from long-standing back pain or sciatica that you've been given an X-ray or an MRI. So tell me which one of these people has back pain or sciatica or any pain. Most people say the person on the right, and I would say that too if I didn't know any better, because that spine just looks a little bit more crooked down at the bottom and it just looks a little bit off. But the truth is that there's only one person who knows which spine hurts or if there is any pain at all. And it's the person whose spine that is. The radiologist has no idea. The surgeon has no idea. The physician, doctor, nobody. Nobody else has any idea based on looking at an image. The first thing I really want you to understand is that you can't see pain. So just because we can see a herniated disc or disc degeneration or osteoarthritis or spinal stenosis doesn't always mean it's the cause of pain. And let me prove that to you. So if we look here at this image, this is showing studies, literature about people who had an X-ray or an MRI, and none of these people had any pain. So the scientists wanted to find out, well, are these findings on the image really the cause of pain, or do people with no pain have the exact same findings? And what they found here is, you can see in the top left, 75% of people in their 20s had a disc bulge in their neck, but yet no pain. Over 87% of the entire population in this study had a disc bulge in their neck, but no pain. The middle graphic on the left is 80% of people at the age of 50 years and older had disc degeneration in their lower spine, but yet no pain. 36% of them had a disc protrusion, which is a herniated disc, but yet again, no pain. We look on the bottom left, 43 out of 44 had a meniscus abnormality in their knee, but no pain. On the top right, 72% had a slap injury. That's a labrum tear in the shoulder, no pain. And if we look on the other image on the right, 69% of people had signs of a labral tear in their hip, but yet no pain. So the thing that I want you to realize, the concept that I want you to realize, is that just because you're shown to have a problem on an image doesn't mean it's the cause of pain. And I'm going to help you make more sense and make this a little bit clearer as we go along here. So the other thing I want to talk about is, because this just doesn't show everything, right? I mean, it shows a lot of diagnoses, but you could have been diagnosed with something different. So I want to make sure I catch all of the diagnoses. Now, there's a lot of text on this slide, and I'm not going to read all of it, but this is just a summary of an article, of a research article, that I want to highlight a couple things on rotator cuff tears. So rotator cuff tears are common, affecting approximately 40% of the population who are older than 60 years of age, 40%. So let me ask you a question. Do you think 40% of people 60 years and older have shoulder pain? Because these scientists found that 40% of people 60 years and older have a rotator cuff tear, but that doesn't mean that 40% of people older than 60 have shoulder pain. So again, the point I want to make is we really have to start questioning, do these findings on an image actually mean or actually cause pain? And if we look in the bottom here where it says, I'm going to skip over the middle part of this, all the text, and where it says, I'm going to start again where it says specifically. So specifically, the authors concluded that approximately 25% of rotator cuff repairs in a typical study failed to remain intact. So what they're saying is that if somebody who is diagnosed with a rotator cuff tear, they go and have surgery to repair the rotator cuff, they found that approximately 25% of those people, when they took another MRI at a later date, had another rotator cuff tear. So damage doesn't always equal pain. That's the point I want you to really understand, is that just because there's a problem shown on an image, on an X-ray or an MRI, it doesn't always mean it's the cause of pain. And I'm going to clear this up even more and more as we go along here. So here's one for osteoarthritis. It says arthritis versus pain. And I'm sorry, the image is a little blurry, but it really is talking about osteoarthritis. If we look at the graph and you look at the red and the yellow, the red is severity of pain. So how the most amount of pain people report at a given age. The yellow is the increase in osteoarthritis, so the amount of osteoarthritis one person has. And if we look at the red and the yellow images, or the graphs, it's showing that as you age, you're undoubtedly going to have osteoarthritis. It's not a matter of if, it's a matter of when. But it also clearly shows that the time when one person has the most amount of osteoarthritis is not the time in their lives when they typically have the most amount of pain. Somewhere between the age of 40 to 55 or so is when the majority of us report the most amount of pain. But yet that's not when we have the most amount of osteoarthritis. If you look at this graph, it only goes to 70, but judging by the graph, I'm sure it would continue moving up and up as you age. But at the age of 70 isn't when most people report the most amount of pain. So does osteoarthritis cause pain? This graph clearly says no. Is it correlated with pain? Yes. So let me clear that up a little bit. Does it cause pain? Meaning, does somebody who has osteoarthritis, do they have pain? No, not always. Are they more likely to have pain? Yes. But the problem with that is that if we say, is somebody who is 70 years old more likely to have osteoarthritis? The answer is yes. and somebody who is 70 years old is more likely to have pain, the answer is yes, over somebody who is, say, 20 years old. So there's a lot of things that are correlated with pain, age being one of them, overall health being another, past medical history, injuries, past injuries. There's a lot of things that are correlated with pain. The point I want to make with this slide is that there's a ton of people who have osteoarthritis who don't have any pain. So we have to really start questioning, are these really the cause of pain, or is it something different? Last one is spinal stenosis, and this is a summary of a literature study as well. So what they're saying is they found 77.9% of participants had more than moderate central stenosis, and 30% had severe central stenosis. And if you read at the bottom, only 17.5% of the participants with severe central stenosis were symptomatic. So the worst type of stenosis, or the most severe as they say, only 17.5% of them had any symptoms. So again, does spinal stenosis cause pain? No. Are you more likely to have pain if you have stenosis? Sure. But you're more likely to have pain with a lot of different factors. So again, we have to start questioning. So when the truth is that I don't want to make the point, or I'm not trying to make the point that X-rays and MRIs are not necessary, and you're just going to find things on there that probably aren't the cause of pain, because they are necessary in certain instances. They're necessary if somebody had trauma. So if they got in a car accident and they wanted to make sure that they didn't have a fracture in their neck, or they had a fall, they'd want to make sure they don't have a fracture in their hip, or some sort of a collision with a sporting accident. That's when an X-ray and MRI are completely necessary to rule out any severe causes of pain, meaning, and you can see as I list there, meaning a fracture. They're also great for ruling out if there's a tumor, cancer, spinal cord injury, or something that's more serious that requires immediate medical attention. And as an X-ray should not be used to rule in the cause of pain without any trauma. That's the key point, is if there's no trauma present, then a lot of times the X-ray or the MRI is going to show something that isn't the actual cause of pain. And it's going to lead you or the physician or somebody to assume what they see on the image is the cause of pain, when in actuality it's something completely different. And I'm going to show you what that is. So many times people they come and they say they want to find the root cause of pain, or they're looking for somebody to find the root problem causing pain. Well, the truth is that there's rarely a root problem. A root problem is saying that there's one problem that's causing the pain, when really that's not the case for almost everybody. If you had a fall and all of a sudden you have a fracture in your shoulder, then there is a root problem causing the pain. It's the fracture. But most people, that's not what happened. Pain came on gradually. It came over time. There's no real trauma that's occurred. Some positions make it better. Some activities or movements make it better, and others make it worse. For that person, there's multiple factors that are causing the pain. Like I said there, pain is almost always multifactorial or multiple causes causing it. So now let's dive into these multiple causes so I don't leave you more confused than ever. So let's just talk a little bit about pain and how it's generated, how it works. So what's in charge of pain? Well, it's the nervous system. It's the brain. It's the spinal cord, nerves, and the brain. That's what's in charge of pain. That's what's ultimately going to decide if you start to feel pain. The nerves send a signal to the brain, and the brain just has to make a decision on whether there's a problem or whether there's danger or whether there's trauma or whether there's some sort of form of threat. And the brain is forced to make the decision on whether you feel pain or not. It's not the degenerative disc. It's not the herniated disc. It's not the osteoarthritis. None of that is ultimately in charge of deciding whether you feel pain or not. It's the nerves and the brain. And that's why if we go back up here, that's why a lot of people who have these findings on an image have no pain. Because it's not the findings that are in charge of it. It's ultimately the brain that makes up the decision on whether you feel pain or not. So I have a whole presentation on the nervous system and its role in pain. If you want to watch that, you can find it on YouTube if you go to Kaizen Physical Therapy's YouTube page. And you can watch an entire presentation that's solely based on how the nervous system works and its role it plays in pain. But ultimately, the one thing I want you to know about the nervous system or about pain in general is that pain is typically for protection. It's your nervous system and brain trying to protect you. It's not because there's already damage present. And I'll prove that to you as we go along. So pain is for protection and this is the person that I'm really talking to in this lecture. If there was no traumatic injury, there was no fall, there was no accident, there was no collision, there's no trauma present that you're certain of. And the pain is intermittent. That means, it comes and it goes. Some days it's better, some days it's worse. The weather changes and my pain gets worse. It warms up, I feel better. It doesn't always follow a consistent feeling depending on what I do. So meaning some days, sometimes it's better, sometimes it's worse. That's when pain really is for protection. It's not damage, because if it was truly damage, then the pain should remain consistent if the pain is due to the damage. Because why would the damage change from one day to the next? But yet the pain changes. But if it were the damage is still there, assuming that you were diagnosed with arthritis or degenerative disc disease or spinal stenosis or herniated disc or something like that. The damage is still there, but yet the pain changes. Why is that? Well, it's because it's not due to the damage. The pain is due to protection. It's your nervous system trying to protect you because it feels threatened. Typically, it's because it feels threatened with some sort of posture, some sort of position, or some sort of movement. And that's what makes it better or makes it worse. So that's who I'm really talking to. Is you're going to find a lot of value in watching the rest of this presentation. If your pain comes and goes, it's intermittent. Some days it's better, sometimes days it's worse. There's no trauma, no injury that you can think of that really caused the pain. Or if there was trauma, it's been 3 or 4 months or longer. Because if there was trauma, after 3 or 4 months, that should be healed. And if you still have pain, then it's way more likely that it's due to the protection and the phenomenon that I'm going to be talking about more as we go along here. Okay, so and let me prove this to you just a little bit more, is if I sit for a long period of time, and I start to have back pain or sciatica pain, does that mean that there's damage with me sitting? Did I just damage something by sitting for a long period of time? No. If I bend forward to go and pick up an object or even just walking, if I'm walking, all of a sudden I start having back pain or sciatica pain, does that mean that there's damage that's causing the pain? No. It's not damage, because how are you damaging your back by just walking? How are you damaging your back by just sitting? How are you damaging your back by bending over to pick something up like this lady here? If that causes pain, it's not because of damage. It's for protection. Your nervous system is trying to protect you from some form of threat with that movement, or with that posture, or with that position. And nearly all of pain felt is due to the nervous system trying to protect you. It's not because of damage. And I'm going to help you diagnose, or I'm going to help you start to understand what the problem is that's causing your pain. And remember this, how we went over this, how many people have findings on an image that have no pain, but yet there's other people that have these findings that do have pain. So it's not the findings. For most people, it's not these findings. It's this. The nervous system's trying to protect you. So pain is the brain's opinion of how much danger you are in. And that's a key point, is the brain is forced to make an opinion. It lives inside of your head. It's not like it has direct contact with the environment or with the world. It's forced to make an opinion of how much danger that you're in. So nearly everyone who experiences intermittent pain, meaning pain that comes and goes, some days it's better, some days it's worse, and nearly everyone who experiences that over weeks, months, or years struggles to share stress and load over multiple muscles, joints, systems, and or nerves. And this is the cause of the pain. It's the inability of the body to be able to share stress and load over multiple muscles, joints, systems, and nerves. And that's where I'm going to take it from here, is really dive into what do I mean by this, because I want you to be able to understand this. So if we look at back pain and sciatica pain, that's what the red is trying to illustrate here. If we look at this and we just assume that let's assume you have back pain with the skeleton here, your right side hurts, the back hurts. Well, what about, let's say it hurts with walking. What about the fact that your foot, ankle, knee, and hip all work together with your lower back to walk? So the point I want to make here is that a lot of times the area that hurts isn't where the root cause of the problem is coming from, because it's not like we walk on our backs. It's not like we really do anything directly on our back. We use the rest of our body to move, to squat, to lunge, to walk, to run, to hike. We use our legs and our hips and our knees and our ankles and our feet. And if there's stiffness or weakness anywhere along that chain, it can start to cause back pain, or it can start to cause sciatica pain. So I want you to realize that the area that hurts isn't the only area that we need to look at as for where the cause of the pain is coming from. A lot of times, or most of the time, the area that hurts is compensating because there's either stiffness or weakness or an imbalance, or as I say here, there's somewhere else that isn't sharing stress and load well. And we need to identify where in the body is not sharing stress well and fix that. Not just treat pain. Pain is a sign that there's some sort of problem. It doesn't tell you what the problem is. So my job is to find what areas are not sharing stress and load well so that we can fix that. And when we fix that, pain starts to go away. So if the X-ray and MRI can't predictively show us what's causing pain, then how do we know what is? Because I've shown you what most people believe is causing pain, but I haven't shown you how can we start to reliably and predictively start showing what the cause of pain is. Because if X-rays and MRIs aren't going to do it, then how can we start diagnosing the cause of pain? And the way we do it is with movement. So I want to show you, and you walk through with me. Remember, you'll always try and remember this, that nearly everyone who experiences intermittent pain has an inability to share stress and load over multiple muscles, joints, systems, or nerves. So now let's find out together if the problem is coming from the spine, legs, or both. Because I told you up here, I showed you, if you have back pain or sciatica, oftentimes it's somewhere in the leg, and you already know because if you Google sciatica pain, the first thing you find is a herniated disc or spinal stenosis or osteoarthritis. So you already know, let's look at the spine, but let's also look at the leg, and I'll show you how to do this to start to learn where the problem is coming from. So here's what I typically find with people who have sciatica pain or low back pain is they'll be limited. So there's tightness and stiffness or some discomfort in these movements. And I'm going to show you these movements so you can do them with me. So spinal extension plus a deviation, I'll show you what that means. So extension is bending backwards. They'll be limited in spinal rotation towards the symptomatic leg. I'll explain all of this. Spinal lateral flexion towards the symptomatic leg. They'll be limited in hip flexion, limited in hip internal rotation, limited in terminal knee extension, and they'll likely have a single leg balance dysfunction. So let's dive into what all of this means. And I want you to, the best thing that you could do is pause this as I go through this with you. Pause the video, perform the movement by yourself so that you can start identifying where the problem's coming from. So if I look at, here's the spine findings that I typically see. So here is, so I'm assuming, let's assume the pain is on the right leg is what I'm doing there. So pain is down the right leg, sciatica is down the right leg. Here's what I typically find. When someone bends backwards, they'll deviate away from the symptomatic side. So I'm exaggerating in this video just to make the point known. But they'll deviate away from the symptomatic side as they bend back. And I'll explain why that is in a moment. And then the next one we'll look at is rotation. So rotation to the right. So rotation to the right, or rotation towards the symptomatic leg. So again, let's assume I have sciatica on the right side. Rotation right will be either tighter, more painful, or more limited than rotation to the left. Okay, and then the last one is side bending. So what I want you to do is bend backwards just a little bit. Bend back just a little bit, stay there, and then take your arm down your leg. And what I typically find is that the person will be more limited, bending towards the leg that is in pain when we compare it to the opposite side. Okay, so next one. So here's the other thing we want to start doing is let's now identify, is it really the back that's the problem, or is it the legs that are the problem? Because again, the pain is a sign that somewhere in the chain isn't sharing stress and load well enough. So now I want to help you identify, is it the back that's the problem, or is it the hips and legs that are the problem? So let's assume that when I bend backwards here, let's assume that I have some low back pain, some low back tightness, or I start to feel sciatica down the leg. Well, now what I want to do is I want to take the legs out of the equation, because standing, it's requiring my back my hips, my knees, my ankles all to work together. But if I lay down on my stomach here and I press up, now what did I do? I took the legs out. Now the legs aren't having to work. It's just my back doing the movement. So if standing hurts or standing feels tight or discomfort, and you lay down and you press up and it feels better, or you have more mobility, then what we just identified is that the back is likely not part of the problem. A lot of your problem's coming from the legs, somewhere in the legs. And I know this is, and if I go back here, so here we're testing back, legs, hips, ankles. Here we're just testing the back, so the legs aren't having to work. So if I feel better here by ruling out the legs, but I feel worse standing, we know that the legs are part of the problem. Okay. Next one is seated flexion. So a lot of people will have pain or discomfort when they bend forward to touch their toes. They'll feel tightness here or a lot of tightness into the back of their legs. Well, this movement, we rely on the hips, the knees, the ankles, the back, all of it's doing the work. So what we can do is rule out or take out the legs and just have the back do the work so that we can identify where the problem is. So then if you sit down and go ahead and touch. So what do we just do? The back is still having to work, but the legs are not. So a lot of times people will feel a lot better in the seated position when they bend forward than the standing position. If that is the case, we just identified that the legs are where, at least in part, are where the problem is coming from and not as much as the back. Okay, so next one you want to do is rotation. So we can rotate right, rotate left. Now again, most of the time I find somebody who with rotation, as they rotate towards the symptomatic leg, that's the side that's more limited, more painful, more tight. So what we want to do is identify in the standing position, it requires ankle, knee, hip, and spine. Well, if we sit down, sorry about that. If we sit down, we take the legs out of the equation and rotate from here. Now we're just looking at the spine. So if you feel better in a seated rotation than you do in a standing rotation, we know that the legs are definitely part of the problem. The next one is a lot of times hip flexion will be limited here as well. So hip flexion on the symptomatic side. So lie on your back, you pull your knee to your chest. The hip that, let's say if I have pain on my right side, the right hip, as I bring it to my knee, will be more limited. Dang it, I keep doing that. Will be more limited than the hip on the opposite side. And many times people will feel some sort of tightness in the front of their hip. Some tightness or pain, not always pain, but not typically, if hip flexion is part of the problem, you're going to have some hip tightness in the front of the hip. Hip internal rotation. So as we lie on our back, here's how you can test it. Just bring that knee down and across and compare it to the opposite side. What I'll usually find is the side that the painful side will be more limited when we compare it to the opposite side. So we're identifying if the hip is part of the problem. And then last is terminal knee extension. So as you push your knee down into the table and compare that to the other side, most of the time the leg where the pain is felt will feel tighter, or you'll feel a stretch as you perform this movement when you compare it to the opposite leg. What I'm showing here is you could grab somebody else, your significant other, kids, or whoever, and have them push down on your knee. And most of the time, the side that the pain is felt, that knee will absolutely be tighter when you compare it to the opposite leg. Oh, and here's the last one, is single leg balance. So the balance will be, you just bring up one leg and hold, typically for about 10 seconds. And the symptomatic leg is usually going to be worse with balance than the non-painful side. So I know that was a lot of information. Go back, if you didn't, go back, pause it, and you'll start identifying, if you rewatch this, and start identifying where the problem is that's causing your pain. And if you believe me that that load intolerance is the underlying problem, then this next slide will make perfect sense, okay? If I circle back around to the slide that I talked about, most people with intermittent pain are in pain because somewhere in the body is not tolerating load well. Somewhere in the muscles, the joints, the nerves, or systems is not tolerating load well, and pain is a sign of that. So what we need to do is we need to find the areas, and I've shown you those videos will help you start to identify the areas that are not tolerating load well. We need to identify what areas are not tolerating load, and we begin to load them. And by loading them, we're going to improve their load tolerance, which will start to decrease the symptoms and pain. But if you believe me that load intolerance is the underlying problem, then this next slide will make perfect sense. None of these will provide long-term relief. So most people try stretching, massage, dry needling, or acupuncture, pain meds, injections, electrical stimulation, spinal adjustments. None of these are going to provide long-term relief. And the reason why that is because none of them are helping improve load tolerance. Most people that come to me have tried stretching and massage. Those are the two first things that people typically try. Stretching is number one. And it provides short-term relief, but not long-term relief. And the reason why is because it's not improving load tolerance. So none of these are. If you want to get rid of pain, get out of pain, and produce a long-term outcome, you need to find the areas that aren't able to tolerate load well enough and load them so that they begin to improve their load tolerance. And that will start to decrease pain. So again, find the areas that aren't tolerating load well and improve their load tolerance. So I want to show you, because I want to prove to you that what I'm telling you is true and actually works for overcoming pain. So here's a couple of testimonials from past clients. So here's one from Eddie. An MRI revealed a broad disc bulge at L4, L5. So he had a herniated disc. I was offered 3 options: anti-inflammatories, pain medications, and spinal injections, and as a last resort, back surgery. I elected to place my recovery in the hands of Dr. Nilsson. 8 weeks later, I was playing golf and resuming my daily activities virtually pain-free. Now, the second one is from Connie, and she says, I had been experiencing sciatica pain almost daily for 10 months. I was irritable and had difficulty walking, sitting, and standing. I went to see Dr. Nilsson, and he was very confident that he could help me be pain-free. I was somewhat skeptical, which most people are, but after my 3rd treatment, I was no longer feeling daily pain. He also helped me with my back and knee pain. I'm very happy to say that I now have no pain. I went on a trip out of state and had a very nice pain-free experience. It's been a blessing to be able to do all the things I couldn't do before without pain. Dr. Nilsson is a very knowledgeable, caring professional, and I highly recommend anyone who is experiencing pain. So the stuff I'm giving to you is the stuff I use every single day with diagnosing and treating pain. So if you want to try this on your own, and I hope I'm starting to put the puzzle pieces together for you on what causes pain and how to overcome it. If you want to try this on your own, go back to those videos and start to identify where the problems are. If you want my help, I would love to invite you in for a $49 first visit. Somewhere around this video, there'll be a link or a button that will send you to a page to inquire for a visit. The first thing I want to do before we schedule that visit is I want to talk to you on the phone to ask you some more questions just to make sure that my treatment approach is the best approach for your problem. If it does sound like it is, then I'll invite you in for a $49 visit, and together I'll show you what is causing your pain, and I'll provide you some exercises and techniques that you can begin performing to start fixing the underlying problems. Now, I will say that nearly everyone feels some improvement by the end of the first visit, and my average number of visits per patient is in the range of 6 to 10 before they are 100%. If you are interested in getting help from me so that you can overcome this problem for good without pain meds, injections, and surgery, click the button around this video, schedule a time to first talk with me on the phone, and then I'll invite you in for the first visit so that together we can start getting this figured out. Thanks so much for listening, and I'll talk to some of you real soon.